bit different, but I find it rather interesting. Working within pediatrics, sometimes I think we don't realize how much our subconscious bias or our immediate decision-making might fall into play. And so I felt like it was important to have a discussion about this, just to gain greater understanding of what goes on and what the background is. Okay, so our first case, once again, I'm going to do this kind of case-based, although what I'm going to do is I'm going to read out two different cases, although they're both very similar with similar ideas. And then I will go into my subject preparation rather than bringing up different cases. And basically, what I want everybody to do is to kind of think to themselves, you know, when have I been in a situation where a patient comes into me and for some reason I can't comfortably interact with them? Something about them is a little bit different, a little bit challenging for different reasons. And what might I be able to do to be able to change that? So this is a case that I had actually recently in the emergency department. I work in an emergency department in the New York City area. We've been very, very busy recently. And so when we have patients that are a little bit time consuming, yet not necessarily ill, it becomes very challenging to truly focus on them and try to give them as much time and energy that they truly deserve. And this is that kind of a case. So a 6-year-old girl was brought into the office by her mother for evaluation of headache. Upon walking into the room, you realize that you saw this patient 3 times within the past 2 weeks. And realizing that in an emergency department, we see so many patients. And so the likelihood of us seeing the same patient 3 times probably means that the patient has been there more than just those 3 times. So, you know, I think to myself, it's important for me to go back and review what's been going on with this patient through our records here in the hospital. The patient is very well appearing, has normal vital signs, normal exam, normal neurologic exam. And basically she already had quite a bit of lab work done, as well as a CAT scan. And the mother insists that she's persistently complaining about headache and that it's stopping her day-to-day activities, and she brings her in. Now, of course, a headache in a 6-year-old girl is something that's very concerning to me, but the child sitting there on an iPad, playing happily, comfortably, in no distress or no visible distress, no medication has been given to the patient. And, you know, it makes me wonder exactly what it is that's going on here, because we've already kind of evaluated some things. An MRI was not done. So yes, there are things that could have been missed, but overall, she's had a fairly extensive, maybe even more than necessary extensive evaluation for her headache already. She's been referred to a neurologist. She's had all kinds of stuff done. And the mother is very pressing, saying how important it is, how anxious she is, how concerning this headache is, and how it disrupts the family's day-to-day activity. In fact, she mentions that they were in Disney World the week before and that she had to cut her trip short and come home because of this little girl's headache, which of course makes me very, very concerned and very worried. Yet there's something about the whole situation that doesn't sit well with me. And so my immediate visceral reaction to this kind of a case is, well, what am I going to do for this patient now? How am I going to help? What's going on? What's wrong with this situation? And the next case is fairly similar. You walk into the next room and there's another patient who comes in all the time complaining of abdominal pain. She seems to come in at least once a month, if not more than that. And when you start trying to get ready to send her home, she gets very upset. She doesn't want to go home without any medication. She wants something, yet she's kind of already had everything. She has had extensive lab work done. She's had imaging done, and she even sees a GI specialist, but she still comes into the emergency department on a regular basis. And each time she comes in, you notice her name on the screen, because now everything is computerized. And so we're given a heads up as to who's out there and who's coming in. And you wondered to yourself, what am I going to do about this patient? And once again, your immediate reaction is, oh no, not that one again. How am I going to deal with her? And so these kinds of patients are some of the patients, I would say, that subconscious bias comes into play. And the whole idea is that sometimes a patient can come into you and you don't even know like why you react in that way. And sometimes that reaction feels more like a positive than a negative, but more often than not, I think it's a negative interaction. And so when we go back and think about what's going on, we go back to Freud. And Freud had an idea of something called transference and countertransference. Now, these ideas initially were used within therapy sessions, within psychology. But the reality is that even in the medical world, or really in almost any world, when you interact with another individual, you're going to transfer your feelings to them and they're going to transfer feelings back. Or more so, once you meet them, you get this immediate reaction sometimes. You look at what's going on and perhaps you judge them, although you might try not to, but it's kind of an instinct. And so, you know, this is what's going on with these patients, that we see that the patient is coming in and we automatically have a reaction of not really a panic, but an idea of what am I supposed to do about this? Because this patient is just persistently pestering and we seem to be doing as much as we possibly can, yet it's hard to recognize what's really going on with the patient. So basically, reactions may cause a judgment, altering our decision-making process. And this is something that we really have to be very, very careful about, because you don't want to change what your decision-making is. You want to be able to see the patient clearly and interact with them, get a complete history, get an appropriate physical exam, make sure that you make an appropriate judgment on the patient without any interaction of any biases. Yet what's falling into play is we're doing something called a cognitive bias. Cognitive bias is broad in that there are many different types of cognitive bias, but what I'm focusing on here is something called a halo effect, or the tendency for an initial impression of a person to skew what we think of them overall and not allow us to really see what's going on. It's kind of the idea that you know, sometimes the forest is going to actually obscure each individual tree and not allow us to really understand what it is that's going on. So cognitive bias may hinder judgment and create challenges in our doctor-patient relationship. And, you know, there's really nothing that we can do about that. Sometimes these kinds of things just get in the way. So there are two important articles that shed significant light on these kinds of emotions that are evoked and the responses that we have. The first one is one called Taking Care of the Hateful Patient, which was written back in the 70s. It's a New England Journal of Medicine article in 1978. I think it's worth a read because it really kind of sheds light on what goes on in these situations. And the other one is something called it's once again just reviews it. It's the Hateful Patient Revisited. And basically it goes over the exact idea and kind of discusses what's new, what's different, how can we think about this differently? And actually in the present day and age with computer and technology, with patients Googling things all the time, we fall into a whole different ballgame. So I'm going to go through the 4 different types of patients that are mentioned within this article. They're very similar, but definitely we can all relate to these patients because we see them all the time. And I think the idea is that if we recognize that these patients exist, perhaps we can limit our angst and our reaction to the patient. So the first one is something called a dependent clinger. And basically this is a patient who presents with somewhat minor complaints, yet accesses boundless time. Every question spurs on a new one, but the patient actually is kind and caring, and they're constantly being positive towards the physician and towards the staff, and they overly flatter. So sometimes they can give us a good feeling and we become happy to see them, but even so, that can skew your relationship and your medical judgment. And so they're very important to recognize. And so how do you respond to that? Because this is somebody that when you're in a busy office environment or a busy emergency room environment, they try to take up all your time. So basically what you need to do is give them exact, succinct, precise answers and very careful instructions. And hopefully with that kind of an interaction, they're going to be able to help you out. The next one is something that we call an entitled demander. So these are angry patients. So this is somebody who, similar kind of thing, they come in with frequent minor complaints, but when you start to interact with them, they automatically will respond with anger and aggression. And staff are very anxious when this kind of thing happens. And so what's important to do is, number one, to recognize it, to recognize that their angst and anger is coming from somewhere, and rather than responding to it, to help them cope with it. So you need to try to stay calm. You need to recognize that the patient feels a lack of control, and so they need some help. And you need to validate their feelings, try to calm them down as well, and try to help them understand that anger might not get them where they want to be. The third patient is what we call a manipulative help rejecter. Once again, these are patients who present with multiple symptoms, and each response will evoke a new complaint. So if you solve one problem, there's going to be another one. And basically, they're trying to manipulate this physician and staff. They're trying to get what they want, yet sometimes they don't even really know what they want. Sometimes they're there because they need to be able to speak with someone, to talk to somebody about perhaps their medical needs or even just their day-to-day psychological needs. And basically what you need to do is you need to set boundaries with these kinds of people. You need to develop a systematic way to help them. In an ER setting or in an outpatient clinic setting, it's often important to arrange other physician meetings, to encourage regular doctor meetings, and to make sure that they're set up to be able to answer their complaints. And then finally, a patient that we do frequently see is a self-destructive denier. And these are chronic patients who kind of reject help. So often in the emergency department, these patients are alcoholics. But when we're dealing with children, because this is a pediatric presentation, there can be parents also who just don't really listen, or they don't seem to listen to what you're telling. And so they keep on coming in with the same thing, but not having followed what you recommended before. So, it's very hard to deal with these patients, and it's hard to understand what it is that's going on. But the reality is, with all four of these patients, because yes, they have very strong similarities, there are similar ways for us to cope with them. And I think it's very important to have a little bit of an understanding of how we might cope in order to help our patients best. So basically, what are we going to bring along with us? What we like to say is what would be in our toolbox in order to assist with these patients? Well, I think that the most important thing is having some empathy. Basically, putting yourself in your patient's shoes and saying to yourself, well, why is this patient reacting in this way to me? What is it about their life or their day-to-day existence that's provoking them to come to my office, the emergency department, so many times? I need to try to see their world through their eyes, and I need to try to understand what they're feeling that's going to provoke it. It sounds easy. It sounds like something that we can always do and always want to do. Yet I think it's hard, actually. And I think that all of us are very, very busy. And often the patients that are present in this kind of way are not our sickest patients. And so we don't want to be dedicating all that time to them, but we have to stop ourselves for a second. You walk into a room, you have to sit down with them and make them understand that you do care about what's going on with them and that you do want to help them, yet also set limits and make sure that they get what your perspective is. Let them see you as a human being, because that's very, very important. And then the other aspect, or the other thing that we truly need to have in our toolbox, is our own personal ability to discuss these patients with others. Not necessarily that patient. You don't want to share information inappropriately, but you do want to be able to interact with your staff kind of in a positive sense, so everybody can put their feelings out there, because discussion is what allows us to cope better with our feelings. So just a little word cloud of all these different ideas, but the reality is that it's often very, very hard in this busy day and age to stop and think and listen and recognize the fact that our patients are coming to us with seemingly minor complaints, but there's something that provokes them to come. We really do have to try to connect with them and hear what they're saying, and we have to provide them and be very empathic with them, because without that, I don't think that we can necessarily create a great relationship with them. And then the final point is something called shared decision-making. So in the United States, I think we have been trying to be very big on shared decision-making. I don't know how it is across the world, but the basic idea is that years ago, the physician would be the one making all the decisions. We would basically tell you how to do things, when to do things, and what's necessary to make sure that it's done. And we would expect that you would listen, and then we would move on. We might not even really make sure that you're doing it. We might not listen to see if you have questions. We might not be able to give you the time of day, and we might speak above you and not use language that you can understand. But today's physician is a very different one. Nowadays, we try to interact with our patients on a one-to-one, person-to-person basis. So perhaps we have a different background, we have a different understanding of what's going on. We can recognize illness in a different kind of way, but we want to be actually in the same place, and we want to help make decisions together. And certainly this is very important with children and with parents, because we do want the parents to feel as if they have control. We want them to understand goods and bads and be able to ask questions. And therefore, shared decision-making is very, very important. I even make an effort to try to involve children, even young children, just, in the same way that we'll ask them where to do a particular procedure so that they feel like they have a sense of control. Allowing a parent and the child to interact together allows the parent also to understand that the child is thinking about what's going on and does have thoughts and does have opinions, and allows them to work together as a team once they get home, which is very, very important. So basically, the point that I guess I'm trying to drive home is that real human reactions and emotions really do facilitate patient interactions. And so although, we're always taught to be the physician, to walk into the room and have a stiff upper lip and be the doctor and not show any emotions at all, I think that things have changed. And the reality is that nowadays it's okay to show emotions. It's okay to reach out and make sure that the parent understands what you're going through. It's best to sit down and really speak with them carefully and make sure that everybody is listening and on the same page, and have a back and forth with a question and answer with the patient. Have the patient or the parent repeat back to you so that they can really show that they're understanding. And only through that kind of an interaction can we really gain, I think, at this point. So that's a just brief little talk, but I wanted to really help people understand, or try to open up the screens to have a little bit of back and forth, if it's a possibility, about this subject matter. Thank you so much.
Thank you, Dr. Mirjana.